So, first question, Dr. Ben Amr. What is the meaning of primary failure or secondary failure?
So, a primary failure if you give a patient a medication for the first time and he did not respond at all. Secondary failure if you give the patient treatment and he improved and then he lost the efficacy. This is the secondary failure.
Thank you. A second question for both. Now, usually systemic therapy used before is needed to, now that they're talking about the step-up approach for the management of psoriasis. Why shouldn't we usually start with biologic before having first and second line?
Okay. Actually, once we develop these national guidelines and we use to categorize the lines of treatment, we study and the class review and the efficacy of each of those medication on psoriasis, the side effect, the cost effectiveness, and we study also the budget impact before even choose any of those treatment. For all those benefits, we try the best to have better patient and choose better patient and the correct patient for each specific treatment. So we reach to equity and equality of treatment and best quality treatment for our patients.
Thank you, Dr. Dr. Yusuf, do you want to add to this question?
In my opinion, it is only cost. Thank you.
Okay. Thank you. Patient on psoriasis use psychotherapy treatment. Can we use immunosuppressant treatment at the same time?
Phototherapy or what?
Yes, patient on psychotherapy treatment. Can we use immunosuppressant treatment at the same time?
Maybe they mean phototherapy, not psychotherapy. Psychotherapy, it's fine. Actually, ideally, all patients with any chronic skin condition, they should have some sort of psychotherapy. But I think he is meaning by phototherapy. For phototherapy, you can combine retinoid, you can combine sometimes methotrexate, even if it is in the old textbook, they said it is photosensitizer. I do sometimes combine it with cyclosporin, but be careful that theoretical risk of skin cancer, because cyclosporin is carcinogenic. With biologic treatment, I have no concern with that one.
Thank you. Last question, and then we'll allow one question to the audience. If patient is on TNF, then due to unavailability, what is the next best medication, whether it is a biologic or a new molecule?
If the medication is not available because logistic things,
yes.
Okay, I think it depends what do you have in your portfolio. Whatever you have, it will be a replacement. But I don't recommend quick switch between biologic.
True.
This we will end up with no other medication available. Quick switching is the worst thing in the treatment of chronic skin condition.
Patient stable. Yes. Dr. Maisa, do you want to add on to this question?
Yes. If it's according to the lines of treatment, most of our patients, due to previous MOH formulary, was on anti-TNF. So if this patient from our old patients, then we should evaluate for risankizumab as a first line after anti-TNF. If the patient failed after Risa and ixekizumab, then we can try interleukin 23 antagonist. Thank you.
Thank you, Dr. We'll allow one question from the audience, if any. Tfadal, Dr. Naif.
Just a question you mentioned that some of the patients in the registry have psoriasis and psoriatic arthritis. Is there any information about the response, the efficacy of Risankizumab on patients who have joints pain, who have psoriatic arthritis too? We know that works very well for skin, but what about joints?
There is a lot of information did not mention here.
Okay.
I will show you the analysis once we start our registry in collaboration with you. So I can announce here that our expansion of psoriasis registry is to include all dermatologists to have BSA with BSO.
Thank you.
One last question. Regarding the guidelines, how likely is the patient to respond to a TNF inhibitor after failing interleukin-23 and interleukin-17 inhibitors?
So the study showed that interleukin-17, interleukin-23 is more effective. Though sometimes we are surprised that even sometimes patients who failed on some medications, they might go and respond to old medication. I have few patients on etanercept. I don't remember when was the last time I prescribed it, but they're still happy and I keep them the same thing. So sometimes going back to the old medication, it might help. We have some patients who failed some biologic for psoriatic arthritis and psoriasis, and we put them back on small dose of methotrexate, and they make the magic for them. So don't forget your old medication. Sometimes it's handy.
Thank you so much. For our online attendees, please stay tuned at the end of the conference if we are being able to answer all your questions. We are breaking up now and we reconvene exactly after 30 minutes. So we're back here at 4:15, inshallah. Thank you.